Well, hey, everybody, this is Robert, and welcome to Outbreak News Interviews. Now, today's topic is going to be meningococcal meningitis. And there's a new article out by doctors Andrea Prinzi and Rodney Rohde that were published on the American Society for Microbiology website that discusses several aspects of this dangerous bacterial disease. In addition, it's chock full of history that you may not be aware of. So, joining me today to talk about meningococcal meningitis is Rodney Rohde, PhD. Dr. Rohde is the Associate Director of Translational Health Research Initiative at Texas State University. Dr. Rohde, welcome back to the show.
Hello, Robert. It's always great to join you. Looking forward to talking about some microbes again.
There you go. All right. So let's start out with some basics. What is meningitis? And more specifically, the topic of the paper, what is meningococcal meningitis?
Yeah, so pretty broad topic, right? If you really get into meningitis. So typically we think of meningitis as really any, serious inflammation of the tissues surrounding the brain and the spinal cord. Typically it's caused by some type of infection. I mean, it literally can be bacterial, which we're going to focus on today, but it could also be viral. It could be parasitic, and it could even be fungal. In fact, you might have seen in the news over the past year or so, we were dealing with fungal meningitis due to some Mexico healthcare situations. So it can really happen across all the microbes, and it can be fatal. And it often requires not only immediate diagnosis if possible, but certainly immediate care. And I know we'll get into that later. But typically transmitted from person to person as well.
Okay. So this is a bacterial infection. What's the causative agent?
Yeah, so for a specific topic today, we're talking about meningococcal meningitis. It's caused by the organism Neisseria meningitidis, which is a gram-negative coccobacillus, typically exclusively infecting humans.
Yeah, and there's several common types. How do they differ?
Yeah, so I mean, kind of got into it. If you're talking about the different microbial groups, so there's different groups that can cause that across all the groups, and then even within bacterial species, we're speaking specifically about Neisseria today, but there can be strep pneumo cases, there can be listeria cases. People hear about listeria in the foodborne area, but it can also cause meningitis.
Right.
And even E. coli meningitis. So there's a number of bacterial species that can cause the pathology and the disease class of meningitis.
And within Neisseria meningitidis, there's several subgroups of that too.
Yes. So we have serotypes, and when we jump into even some of the vaccine information later, there's A and C and Y and some other difference based on protein structure.
Right. Now, there are actually two most common types of meningococcal disease. Can you go ahead and discuss the differences between the two?
Yeah, generally we refer to the two primary types of meningitis as the one we kind of just mentioned. It's really the primary infection of the brain and the spinal cord, and that's referred to typically as just meningitis in those areas. But, and this has happened in a recent outbreak in the US and elsewhere, it can also be seen as a bloodstream infection. And usually that's going to lead to those primary conditions that we know is sepsis, which is, an extreme kind of response to a bloodstream infection, can also be very deadly. And we often refer to this as meningococcemia.
Yeah, and oftentimes when you hear of an issue with this organism, that's how it's described as meningococcal disease,
Right.
basically regardless of which type it is.
Right.
Let's talk about the symptoms of meningococcal disease, because some of these are quite distinct.
Right.
Others are very overlap with so many other diseases.
Yeah. So again, like a lot of these things, we seem to be talking about this all the time when we visit. Unfortunately, some of the symptomology around this particular disease can be similar to flu-like symptoms, right? So you can have things like a headache. One of the things that sometimes stands out about meningitis would be a stiff neck. So that kind of is the unusual. Fever, confusion, right? So I work in the world of rabies. Rabies can show this type of brain fog, kind of confusion, some mental issues around that. Light sensitivity, that's also associated with really bad headaches and migraines associated with meningitis. and then good old nausea and vomiting. So that's kind of the general. But when you end up with bloodstream, infections and things like that, that can cause those hallmarks of sepsis, which could be multi-organ failure shutdown, leading to mortality pretty quickly sometimes if you're not on top of that. So very broad, and then some very distinct type of hallmarks like that stiff neck, mental confusion, light sensitivity.
And there's the petechiae that you can see.
Yes,
Yeah.
thank you. The rash piece and the
Yeah. In Dr. Rohde, the death toll can be quite high for this pathogen.
Yeah, it really can. And I know we're going to talk about prevention later. That's why it's so critical, right? That if an infant or even a young adult or anyone else is coming down with meningitis, because the death toll, the mortality of this particular virus can reach into the 10 to 15 percentile.
Yeah.
It's pretty high, 1 to 2 out of 10. And this can happen even with appropriate antibiotic therapy or supportive care if it's getting later in the game, if the organs have gotten involved and things like that.
Yeah, in concerning survivors of this disease, there's some lifelong complications that can go along with it.
Yeah, and including in my own personal experience, I thought I'd share this. When I was working with the Department of Health in Austin, we had the unfortunate incident of we think a laboratory acquired infection, which can happen.
Yeah.
The person had been vaccinated, but it had been really long ago. He was an older gentleman. And so some of the things I'm going to talk about here, like you can lose tips of your appendages due to necrotic tissue and things like that. So he literally lost parts of his fingers and toes. So these kind of long-term problems. You can have hearing loss from minor to total. You can have ongoing seizures that could lead to epilepsy, for example, can affect your vision, brain issues, brain problems, overall muscle and nervous system problems. Again, remember what we're dealing here with respect to the nervous system in the brain. So it kind of impacts everything: behavioral changes, speech, memory, coordinated, the ability to be balanced, weakness in your limbs, and significant joint pain and ongoing problems there. And it literally can get into organ problems like heart, kidney, and other things. And then lastly, and it's always brings me back to kind of rabies too, because I know we talk about that sometimes, but survivors can experience anxiety and depression, sometimes not seen in the literature as much. And they can become really concerned about, am I getting it again when they have an illness? So there's a lot of anxiety around it. And sometimes they need long-term therapy, including supportive therapy, but both mental and physical types of therapy to kind of get through it. So it has a really devastating impact on survivors as well.
Yeah. How does somebody contract it? This isn't an airborne thing like measles, for example. This is more close contact.
Yeah, it really is primarily close contact. And the other thing to mention about this particular bug is that approximately about 10% of the population will carry it. Mm-hmm. So most people, not most, some people will be colonized in the oropharynx, kind of the middle part of your throat at any given time. And so that colonization is also a factor that can lead to infection and even outbreaks. So that's kind of unfortunate. And if you look back historically, which our paper does a little bit, like the 19th century and some of those times when people were slammed into tight living quarters, you can imagine all those situations: prisons, homes, military types of enclosures, and that super close contact, that person to person, really for any type of infection that's person to person, becomes a problem. And so it can really affect almost anyone. But some populations are really more at risk, like babies younger than about a year, maybe 18 months old, adolescents, and even young adults. And, this, again, we've talked about it a lot, but this is why it's so critical. To this point, your question is even 17, 18-year-olds that are entering college, for example, in many states, it's a required vaccine because you're going to be in a dormitory type of setting, and so you're trying to prevent some of that spread.
Yeah, I know a lot of the cases that we typically see in the U.S., other than some of these big outbreak cases, are from university
Right.
settings, dormitory. And I can recall many moons ago when I went into the military, that was
Mm,
a big concern among the barracks and that
right.
close contact.
Right. And of course, if you're working as a laboratorian or in research, you're probably going to be, make sure you're vaccinated so you don't have those accidental exposures.
Um, no, we're talking about the United States. This is not Africa, but how many cases do we see on an annual basis here?
Yeah. So in the U.S., it's again, it can really impact a lot of age groups. So we already mentioned that, but it kind of varies. I know the paper that you referenced, we put up a graph that's data from the CDC for the United States. It's from like 2006 out to about 2023. But when you dig into the data a little more carefully, in any given year, about 1,400 to 3,000 people are diagnosed with bacterial meningitis. And so when you look at the mortality, that's anywhere between 150 to 300 per year. Again, we mentioned very common in infants, children, college students. We already mentioned military. It can impact elderly and immunocompromised populations.
Mhm.
And it's usually kind of a peak in winter or early spring, but it can occur other times. And when you start looking at the specific data this year, I'm going to read this to you because I looked it up this morning. As of March 25th, that's about the most current date we can find on CDC of 2024, we've had 143 cases
Mhm.
bacterial meningitis reported, and that's an increase of 62 cases over last year at the same time. So we're experiencing a little bit of an increase in this past year or two. We're not really, I mean, we can talk about it if you'd like, but there's viral meningitis, lots of viral meningitis. Usually, fortunately, that's not as deadly, but a lot of cases, for example, 75,000 cases a year. And then those other types of meningitis like fungal, amoebic,
Mhm.
types of meningitis, a little more rare, but we usually have a 100 to 200 case range per year in those types of meningitis.
Yeah, I think it was. I think it was last year in my state of Florida. They were putting out messages concerning the spread among MSM
Right,
in this state, and
right.
I think it was. It may have been nationwide. I don't recall
Yeah,
specifics, but again, close contact.
right,
Yeah.
right.
But then, let's go to Africa, and there's a strip of the continent which they call the African meningitis belt. What's going on there?
Yeah, so in this region, again, meningococcal meningitis is endemic in many parts of the world, and it does occur globally. In that area you talk about, the highest incidence that we know of infection occurs in what's known as the meningitis belt that you just mentioned in Africa. This has to do with the equator and kind of the latitude and longitude section of that area. And they have large epidemics historically about every 5 to 10 or 12 years. Lots of different serotypes that you had asked about early. So Neisseria meningitidis in those areas, sometimes B, C, W, and Y regularly circulate in the U.S., but we also see different types in Africa. And unfortunately, in that part of the world, in those developing countries, many times you've got issues of access to healthcare. You have issues of access to even vaccines and antibiotic treatment and diagnostics. So probably compounding the fatality rate and the number of cases in those types of places.
Yeah. Um, Now let's switch gears more to your article that you and Dr. Prinzi wrote, and you discuss the history of meningococcal meningitis treatment and prevention. And this is basically pre-antibiotics to present. Can you give the audience an overview of this very interesting history?
Yeah. So again, I definitely would encourage you to check out the article because we go into it pretty deeply, but kind of an overview. So again, this disease really wasn't described until the early 1800s by a Swiss practitioner. And after that, it was called all sorts of things like, for example, non-contagious malignant cerebral fever, Diplococcus pneumoniae, Diplococcus intracellular meningitis, and then finally ended up as meningococcal meningitis. And then in the 19th century, the prognosis of this disease was so poor that it only rivaled plague and cholera, which many people know about plague. So this led to a lot of kind of bizarre, unfortunately, medical acts of desperation. What might be termed loosely as treatments, anything from bloodletting, alcohol and opium consumption, even using mercury, and sometimes we talk about a little bit in the paper, cerebrospinal fluid drainage, and then adding intrathecal serum therapy. So there's a ton here. I don't know how much you want me to go into this, but there's a ton here around how intrathecal serum therapy kind of was born out of treating tetanus, diphtheria, and pneumonia back in the 1890s. And you might remember some of these names. Emil von Behring, he actually won a Nobel Prize for showing that he could cure humans by injecting them with serum from recovered patients. So this really brought on the interest in how we could use passive types of serum treatments, whether it was from recovered humans or even producing antibodies in things like horses, for example. And so it really paved the way. And then in the early 1900s, again, some names you might know, Wilhelm Coley and von Wassermann. Some of these are named for tests. Simon Flexner. These are all studying meningococcal serum therapy at Rockefeller Institute in the United States. And so it really inspired many researchers to study serum therapy and immunize and bleed horses. Got a little bit of background in that for rabbits back in my early career. But what was bizarre about this, Robert, is this was intrathecal serum therapy was considered the gold standard up until the time we really got into antibiotics and prevention. But it was very painful and really labor intensive. And what they would do is they would drain about 30 mils of CSF from the patient and then replace it with this serum that had, antibodies to help neutralize the infection. But they did this through what was called a gravity infusion system. And if you can imagine being basically suspended roughly upside down, so your head was below your pelvis, and that's how they would put that serum therapy within that space, that arachnoid space, and they would observe the patient until the fever resolved or they no longer saw those gram-negative diplococci in the CSF. Worked a lot of times, but they also saw a lot of hypersensitive reactions. But this was recommended until the 40s, so right up until World War II. And then, we jumped into antibiotic therapy at that time. And, antibiotic therapy is still useful. But of course, just a quick mention, and the audience probably knows this, but because of those strain types and because of resistance that we see now in the world, it's still kind of critical to know, which exact strain or even genotype we're dealing with, so that we might create different combinations of antibiotic therapies to make sure it's working.
Yeah. Now, vaccines are instrumental in the prevention of this serious disease, and you guys touch on some history about that. So I was wondering if you could give us a little overview on some of the history and something more current, like what's available today.
Yeah, so this is around the 1960s. So the 1960s really helped kind of pave the way for meningococcal vaccine. There was a gentleman by the name of Irving Goldschneider and his colleagues that demonstrated the capsular polysaccharide of some of these, which we've been talking about, of some of these strains. And they noticed that induced protective antibodies against the disease. So that led to the development of vaccines, primarily with simple kind of polysaccharide formulations. They started with type A, and then they followed that with C, and then they had a bivalent, A and C. So that was working pretty well. But those plain types of polysaccharide vaccines were limited because for whatever reason, they didn't do a good job in children under 2. And it probably had something to do with their developing immune system. So that was a problem against carriage in children, in the respiratory tract and those sorts of things. And then that led, thankfully, into the development of conjugate vaccines. It's a really big breakthrough. This was in the early 80s, and they developed what we now know as the bivalent Y and W135 strain vaccine. And then that eventually led to the tetravalent ACY and W135 vaccine in 1982. And that's really been a primary boon to protection. And really at the moment, when you follow ACIP and CDC recommendations, they recommend meningococcal vaccine for all preteens and teens for sure, as well as children and adults that have some type of increased risk for meningococcal disease. Right now, there are 3 kind of primary meningococcal vaccines in the United States. We have, I'm going to read this because this is, again, no recommendation. These all are useful, but this is what we have. We have the meningococcal conjugate, or MenACWY, meaning all those strains are covered. We have the serogroup B meningococcal, and then we have the pentavalent meningococcal, which is ABCWY. So, a lot of the public now is used to hearing these types of, bi, tri, tetravalent things with flu. One day we may be dealing with COVID types of mixtures like that. So all that means is the vaccine's named usually for the coverage that it provides for those different serotypes.
Yeah, I remember several years ago when Bexsero and Coremba, they came out, and it was a huge deal because some of these vaccines did not cover the B strain, and it was
and then
that's where you were seeing a lot of the little outbreaks among university campuses. Turned out to be B.
Yeah. And even when you think about, some people may know this who have grandparents or parents that are aging. When we're thinking about the pneumococcal, the strep vaccines that have, sometimes 8, 10, 12 serotypes, because there's so many strains of that. So, as long as the vaccine can handle those types of differences, it's good. Sometimes, as we know, we have to kind of continue to search for what we hope are universal vaccine coverages. Probably more difficult for viruses because they just evolve so rapidly, whereas bacteria sometimes remain a little more stable over time.
All right, well, let me go ahead and let's jump more into your wheelhouse, Dr. Rohde, and that's laboratory diagnosis. So what's out there for the diagnosis of the agent of meningococcal disease?
Yeah, so like most bacterial infections, we really can use the microbiology lab in a very classic way through culture. Talk a little bit about that, and we can also utilize molecular techniques for this. So when a patient presents with meningitis or a physician suspects that, typically a CSF specimen is going to be drawn and sent for testing. If you have other types of infections, a blood sample might be drawn if you're thinking of sepsis or something like that. And then beyond that, of course, we take those specimens. If we're able, we perform bacterial culture with that. That's still considered the gold standard for most public health and other labs, because it's really approaching 100% specificity. This is one of those bacteria that fortunately you can really grow well and come up with specific species types. The advantages of that, Robert, as we know, is that culture is going to allow us to perform things like serotyping and ultimately susceptibility testing, so that person is getting the best antibiotic treatment. And even once you have that culture in a colony of bacteria that's in pure state, you could also perform, sequencing, other types of molecular techniques on that. Some of the headaches with this is there are some fastidious growth characteristics that might, cause us to occasionally miss something if it's not growing well on certain types of media. We don't have to get into all the differences there, but there are specific media, specific environmental incubation types of temperatures that are appropriate. And, you do have to keep in mind, if someone's working on the open bench with these things, there is a little bit of danger because it's meningitis causing. So you want to be careful with lab types of places where you have good PPE and benches. You can also use, in our world today, of course, PCR, sequencing, MALDI-TOF is talked about in most of the literature now to kind of start looking at not only early identification, but genetic relatedness. But I will caution, again, that, and microbiologists know this, molecular techniques are wonderful, they're powerful, they can do really great things, but it can sometimes be still a challenge on MALDI-TOF and some molecular applications, just for all the reasons we know about, whether it's a poor specimen collection, whether there's inhibitors in the specimen, all sorts of things that you have to keep an eye on. And ultimately, you really can't do the susceptibility testing if you're going straight from, say, CSF and you're amplifying DNA to determine it. You still would like to have that culture so that you can determine susceptibility. So all of those things are, a consideration. Ultimately, the earlier you can get to a diagnosis, the more quickly you can get to treatment. And I always talk about this in our medical lab science program because it's a classic example of how you're not only using microbiology, but you're looking at chemistry profiles for protein and other glucose utilization and things like that. So, there's a classic sugar profile and other utilization by these species. So these are all examples of questions on board certifications for this particular field, but culture is still really useful to determine susceptibility in these types of things.
Oh, even the importance of the gram stain.
Absolutely.
If somebody comes through the ER and you get a CSF or a blood.
Right on. Perfect. Yeah. The great reminder. I mean, a clinical gram stain, I always tell my students, is probably the first and still powerful multiplex test, right? Because you can find out, one, is it bacterial? Usually you might know that it's fungal or something else by chance. And then you can find out if it's gram negative or gram positive, all the things around that classic diplococci, as you mentioned. So a pink diplococci image is going to, immediately be concerning in a CSF, especially.
Yeah. Dr. Rohde, any advice? I know you're not an MD, but I'm going to ask you anyway.
Yeah.
Any advice for the public and for travelers, since we did talk about Africa?
Yeah. So, I mean, it's a great lead, and I always, tell my audiences and people that ask that I'm definitely not a physician. So please always talk with your physician and your team of healthcare if you need to kind of gain the types of advice. But being someone who's worked in the Department of Health and at CDC and public health, I do have a lot of advice and information around this. So we've had several recent outbreaks in the US and globally. Some are ongoing. And so if you dig this up in March of 2024, so not too long ago, CDC issued what's called a health advisory network message. So these will come out periodically. I know Robert shares these in his platforms as well. And this was describing an increased rate of invasive meningococcal disease in the US. And what was unusual about this was that it was really hammering people between 30 and 60, so a little older than the typical population. They were primarily Black or African American and usually HIV positive. So it was really kind of honing in on that population. And prior to that, in 23 and up to 24, all of these cases were presenting as not as meningitis, but more so as what we talked about early, bacteremia and septic arthritis. And even more so in 2024, the case rate went up 18% over that same time period when you compare 23 to 24. And the fatality rate was around 11%. So all these were really alarming to public health and obviously physicians and others. And it was really focused on that Y, the serogroup Y case. And so there's a lot of thought around this, that perhaps there was some waning in immunity, lack of vaccination. We talk about this a lot in the world today. Is a lot of times an outbreak can be really around a perfect storm of all of these things, even displacement of populations and refugees and things like that. So it's really a problem. And as a result of that, we've had some specific recommendations for the quadrivalent meningococcal vaccine, that ACWY. It's a conjugate one. So if you're traveling to countries where it's hyperendemic or epidemic, or you have a population profile, is the one I just mentioned, then you're going to want to be aware of that. And of course, hopefully you're having those conversations with your physician so that you can get the proper treatment. But the vaccine becomes important if you're traveling into those areas.
So let's go back to the article. It's bacterial meningitis, a history of diagnosis and treatment. It's on the ASM website, and I will link to this in the
Thank
show
you.
notes for people that want to check it out for themselves. And Dr. Rohde, I read at the bottom that you and Dr. Prinzi are going to be doing more articles on the history of other infectious diseases in coming
Yeah,
weeks and months. Can you talk about that a little bit?
yeah, I'd love to. First of all, let me give a shout out to Dr. Andrea Prinzi, who couldn't join us today. I know we tried to get her. She's a very busy person,
Mhm.
as many of us are, but she is a fantastic colleague and friend. Her background is primarily, her PhD is totally in clinical and molecular microbiology, and then she shifted it. She works for bioMérieux, so she's a medical advisor and just an expert on susceptibility and breakpoints and all things micro. So I love working with her. She's also a great communicator of science, and so we've teamed up to do a lot of these ASM articles and other things. And what we're working on, so we just got this one out. So I appreciate you talking about it with me today. And then we're working on probably later in August, so it might be early September. We're working on a history of poliovirus. So detailing some of the same types of things. Of course, it's a virus, but some of the things around history on vaccine and some of the issues of a resurgence in certain parts of the world. And then I more sooner than that, I'm about to start working on and developing, and I've shared this with Robert online a few times. I'm trying to put together a dinghy piece for ASM as well. That's, as you know, a really big global problem right now with mosquito-borne dengue and what's known as breakbone disease. So really ties into what we're wrapping up here with, which is awareness of travel. It's something I always like to talk to my students and colleagues and friends about, that I think many of us in America sometimes don't think about risk factors when we travel. And I know you know this from your history and your employment with different experiences, but when you leave the United States and you go to places like Latin America or really South America or Asia or Africa, and really anywhere, right? We could even be talking about in the United States, a different region of the US. You really should visit, in my opinion, with a travel physician or your primary care physician, and even do a little research about where you're going, what's endemic there. Perhaps you need to be worried about malaria, for example, if you're taking a cruise. So just all of those things, how to handle food, how to handle water. Are there insects you should be worried about? Should you have vaccinations or perhaps some types of antibiotics to take with you in case you get, some type of foodborne infection? So all of those types of things we'll kind of discuss in these upcoming articles as well as others.
Well, I'm definitely looking forward to it, and I'm hoping that I can get the two of you together for
Yeah, that'd be great.
future podcast. And I want to thank you, Dr. Rodney Rohde, again for sharing your time and expertise with us. Thank you, sir.
Yeah, thank you, Robert. Again, I love what you do, and I appreciate the opportunity to share more information about microbiology. So thank you.
All right. Have a good day, sir.
You too.